Hello, this is Dr. Connie Lindmeyer. So I'm going to be talking to you about decompensated heart and what that means when we end up with these failing hearts prior to surgeries, transplant, pulmonary edema, cor pulmonale, LVADs or left ventricular assist devices, and pericarditis. So one of the biggest things that we always have to remember when we are talking about our clients that have heart failure is what else is going on? How does that whole body look? And again, a little concept map doesn't have all the linking, but just to give you an idea, you know, the people that have heart failure, have they had an MI? Do they smoke? Diabetes, obesity, hypertension, vascular disease or some component, coronary artery disease, end-stage renal disease? Who is your client? So you can't just look at these problems as one system alone. So back to the basis of our heart failure, and I'm not going to reteach you this. We have systolic heart failures and we have the diastolic heart failures. And as you can see, if you look at that systolic, it's that weakened heart muscle. It is not providing that cardiac output as good as it should because it's a weak muscle. When we look at diastolic heart failures, they can't relax as well. They don't fill as well, and we get less blood, which also leads to that decreased cardiac output. So when we look at these hearts as they're failing and coming into these acute, just old hearts, we start looking at diagnostic criteria. What are we really looking at with them? And one of the biggest things, obviously, we can look at a chest x-ray to look at the shape, but we also want to really look at that ejection fraction. So kind of like we talked about in end-stage renal disease, we have stages of that glomerular filtration rate decreasing that kind of correlates to stages 1 through 5. With our heart disease, as you've learned about with regular old heart failure, we use the ACC and the AHA, and we also use the New York Heart Association that will stage where their heart failure is at. The ACCs, AHAs do the A, B, C, D. And again, are you at high risk for heart failure is an A, or are you at a D? D is not passing, remember. That means it is refractory heart failure. And that's what we're talking about with these kind of hearts. That decompensated heart, meaning refractory to treatment, meaning the meds don't work anymore. We've done what we can. We have to think about a transplant or think about assistive devices. Looking at those BNPs, that even on a good day, their BNPs stay elevated because that ventricle is just working so hard. So just important. Now, again, if they have underlying coronary artery disease, you know, with that workload of the heart trying to pump, is it tired? Other people to think about with that craziness. Like I said, it can be infectious processes, smoking, obesity, family histories, pericarditis that I'm going to talk about a little bit, cardiomyopathies, thyroid disease. It can happen in pregnancies, shock, septic shock. So just numerous reasons why. And again, you knowing, coming to us already, the differences between that right and left-sided heart failure. So some of you have not had an opportunity to see a TEE or trans esophageal echocardiogram. So I'm going to play this little quick video, 3 minutes, if it ever gets loaded. Okay, so the purpose of this also when they do the TEE, and in this case, I was just trying to show you what it would look like because they can do these at the bedside, is they measure the amount of blood that that left and right side of the heart is ejecting. So if you can ever read one, they're easy to find in your patient's chart, but that lets them know. And also when someone's ejection fraction starts getting down to 20, 15, they're hospice eligible. So just like staging a kidney, we can look at the actual heart itself and let us know the volume that those ventricles are perfusing. Okay, so again, you know what left and right-sided heart failure is, but over time, our clients can develop right-sided severe heart failure. So when we look from that right ventricle has to push up against pulmonary vascular resistance, or from diseases that increase what we call that pulmonary hypertension. So things like COPD that we're very common with, a blood clot can do that. Pulmonary fibrosis, it's a terrible disease. They are so oxygen dependent. Sleep apnea over time, and that's why we get concerned about people that are undiagnosed with sleep apnea. But when they come in an exacerbation or have it long term, where again, getting refractory, we're not able to manage it, they're going to be in distress. So when we say pulmonary edema, we most often think of left-sided heart failure, but you have to remember the heart and lungs as a system. And so if the right isn't pumping and the left isn't pumping, it's going to back up. But we have a tendency to see more of that right-sided heart failure. Because again, if that right ventricle cannot push up against the pulmonary vascular resistance, that blood is going to stay out in the body. The JVD, the ascites, sacral edema, and those kind of symptoms. But again, it can turn right into left failure because the whole circuit is shot. So, okay, I don't know why there's talking over this. So you can, I don't know how to pause her. So there, I will pause her there. So what we're looking at in right-sided hypertrophy, again, that right ventricle wall is enlarged. It is due to a respiratory cause. So we know the cause is up on that right, up in those lungs, pushing back. So we have hypoxemia. We will have vasoconstriction. They're usually in acidotic states. Okay. Again, that pulmonary vascular resistance is increased, often seen as a pulmonary hypertension. Over time, the body then always wants to compensate. It will try to increase the number of red blood cells so they can have a ruddy look to their face for oxygen carrying capacity. And that's called polycythemia. then that right ventricle, because it's trying to push and push and push against resistance, it'll eventually fail. And when we see that failure is what we call the cor pulmonale. So again, we can diagnose it with x-ray echoes. We'll look at that CBC for the polycythemia. We will check the BNPs. They'll do a heart cath to rule out other things. Again, normally signs of right-sided failure. Eventually the system will fail and they will just end up in just full-blown heart failure. So when we have left-sided failure, what you will see more commonly is what is called pulmonary edema. That now we have more systemic vascular resistance. That left ventricle has to push out against systemic vascular resistance for whatever reason. So again, the lower our output or perfusion to the kidney, the more the renin-angiotensin system kicks in and conserves sodium and water to try to, because it's thinking I'm not getting any, even though the body's wet. Pulmonary edema usually happens like this, like snap it this quick. And I've got a little video I'm going to show you about. People with pulmonary edema often can like feel fine and then they just tip. But we get very worried about people with pulmonary edema. So this first video is my favorite. It's about 100 years old, but he does a great example of what pulmonary edema is like. Just love him. But again, telltale signs. Now you're going to see pink tinged. Again, those capillary membranes are only a cell thick. They're supposed to be getting oxygen and CO2 exchanges. So you'll see the rupturing of that. This next video I want to show you is fantastic. And it talks about flash pulmonary edema. This gentleman is not known. I want you to really listen because this is a couple that knows his medications. Unfortunately, due to the advancement of his disease, he has been seen in the ED a few times. So they kind of know this couple, but we don't want to be judgmental because listen, they know their meds. So before we get in here, I want you to start thinking of that pulmonary edema is more severe, flash, left-sided heart failure. So orthopnea, proximal nocturnal dyspnea, might auscultate an S3 when listening to hearts. Definitely going to hear crackles and wheezes. Probably going to see JVD as well. Again, that circuit is now failing. Very anxious, cold, clammy, respiratory rates are huge. I'm talking 30s, 40s. And this can be life-threatening. So we have two types. The video I'm showing you is called cardiogenic, and that is where we have pulmonary involvement. Non-cardiogenic is a direct injury, like direct injury or damage to the lung. But let's watch this, but really listen to the communication, because it is, and how calm they remain while this gentleman can't breathe. Notice the abdominal respirations. He's working. Okay, and I'll let you watch the rest of that on your own, but you can see this poor gentleman when we talk about writing an FDAR, you want to be so descriptive about that rate, that belly breathing. I mean, he is not getting good air exchange. The other things that you'll learn about when it comes to oxygen delivery systems and BiPAP and CPAP is once they start vomiting, they will take it off, because if they can aspirate on it. And if you have the opportunity to go to the optional respiratory days, please do, because our RT students do a fantastic job of teaching you all about that. So again, this is when it gets end stage like this. You could hear he had salt the last time. So being, so strict on these diets. And what he had, what's called paroxysmal nocturnal dyspnea. He went to bed fine about 2:30 in the morning. He can't breathe because everything normalizes in that fluid and kind of hits his lungs, and his kidneys aren't able to get it off. So, and then he ends up getting intubated. But this is so common. And if you thought it was long to watch this video for 4 minutes and not much was going on, be that patient that can't breathe for 4 minutes. They're running nitro drips on them. The nurse is trying to start an IV. I mean, there's multiple things going on that show the severity of this poor gentleman. And this is very common, you guys. So this one is we see a lot of, and got to have those conversations about code statuses, because one of these times their heart will just give out. Okay, next one. All right. So in this case, of course, we're going to treat the underlying problems. We don't know why this gentleman tripped this time, but the last time was just because he had too much salt. And that is how bad their hearts are. We're beyond that. You have heart failure, and I'm going to teach you low salt diet. They have to be so strict to their diets. And yes, they weigh themselves daily. As you can see, this gentleman was going into acute respiratory failure. They didn't even bother with a cannula. He came in on a mask, but they ended up putting him on CPAP or BiPAP, whichever one they put him on. We need to be advanced with it. If their kidneys are working, we're going to do diuretics. We will try to bronchodilate them again to reduce that workload of the heart. They were trying to vasodilate with that nitrate. All right. Over time. And again, this is why sleep apnea is also scary, because that right-sided heart failure that can lead to left, but our heart actually tries to remodel. It's a compensatory mechanism, but it's not the best. So definitely these people we're going to do ABGs with, and BNPs, and making sure there's not an infectious process, and how's their hemoglobin and their BUN and creatinine. And as you could see during that flash pulmonary edema, he was having a hypertensive crisis on top of it due to pressures. All right. So everything's backing up in that system again. So not only you're trying to treat the airway, you're trying to keep that pump as effective as possible. And that's why we cover all of this under cardiac and not in respiratory problems, because it's cardiogenic in nature. All right. So then what we're talking about more here is that decompensated heart, and we get them in right and left-sided failure. So they already have a chronic condition. Known BNPs stay elevated on a good day. They're often oxygen dependent. Again, multiple comorbidities. So if you look on this right side here, baroreceptors are what sense our fluid. So again, it's about perfusion. So in this chronic state of non-perfusion, that renin-angiotensin system activates. So we're reabsorbing water. But the problem is we're not responding to it anymore. So we just keep filling and retaining. We come resistant to the drugs. We can't stop that aldosterone. So it gets very, very scary. It is the worsening of the heart failure, and it's a clinical syndrome. They are so dyspneic. It is a rapid accumulation of fluid because, like I said, it just hits that tipping point. And they will monitor their filling pressures, and it's just very scary for them because there's only so much we can do with drugs, you guys, to make that heart better. So again, it's a cycle. So the pathophysiology, we can look on the left, you have a decreased cardiac output and blood pressure. So your SNA and your ANP and your renin-angiotensin system, vasopressin, trying to get that renal artery to adjust. But the problem is you're getting decreased renal flow and you keep reabsorbing, no urine output. So you start getting increased central venous pressure. So that's where our lines start coming in. You start getting increased pulmonary catheter wedge pressure. So we're measuring that both sides of those ventricles to see what's happening. And you start measuring that right ventricle, you're much more invasive. So this picture is just showing you the loop of Henle-Moore in that kidney, what is not happening. But I think it's just important to see it. So again, we can have right and left heart failure, but we look at things, and in his situation, the girlfriend, wife, whatever his significant other was, talking about he got that cold and clammy sweat. So again, what was happening in his picture? So they might be warm and dry. They're back to a good state. That's kind of where we want them to be, this warm and dry. Excuse me. They look like a COPD that has heart failure on this warm and wet side, the warm classic presentation, but we want to get them warm and dry. We got to get that fluid off and get them back to like a COPD and just pray that that right side doesn't tip again. When they start getting cold and clammy like that, we start worrying in heart failure. Are they going into what we call cardiogenic shock? Okay. So we're going to start giving things like ionotropes, dobutamine. We're trying to strengthen that heart muscle with those ionotropes to improve cardiac output. Remember, ionotropic works on heart contractions. Chronotropic works to increase heart rates or decreases if it's a positive chronotropic action. Here's where we're going to give drugs in micrograms per minute. Epinephrine is a big vasoconstrictor, trying to get that pressure up as they're going into shock. Okay. Vasodilators, as you saw, they're trying to, again, because the heart is so bad and the lungs are full, trying to decrease that preload back to the heart, doing everything we can. So just a way of how are they presenting? What do they want them to be? Looking at perfusion, right, down the left side versus the congestion. Where are they at? Wet or dry? It's scary with them. Very scary. So with this adult heart failure, again, he went to bed, he was fine. You lay down flat, you got to sit up. You ask clients, how many pillows do you sleep with at night? Do they have JV, jugular vein distension? I think that should be D. Again, look at these signs and symptoms. It's just a very wet people, and it goes back to that fluids I've talked about with you before. So when they get to the point these pumps fail, all right, they come in too much in acute. And that gentleman's probably a prime example of nearing the end of his life with these exacerbations. His heart just doesn't have the reserve to come back. He's a transplant, okay, but he doesn't probably qualify for transplant status because that's a whole nother thing. And I'm not talking about heart transplants here like we did with renal, but because you really have to meet some qualifications. But he might possibly be eligible for what we call an LVAD, or a left ventricular assist device. So this is kind of like a bridge if you're not a heart transplant candidate, or if you're on the list for a transplant, because we want to keep things moving as well as we can. So again, labs, they're going to do an echo, they're going to do chest x-rays, the BNPs are going to be elevated. The client needs to meet criteria, no cancers. They look at body size, body type, the client's nutritional status, the ability to do a sterile dressing change because infection is so scary with these. Also have to consider, do they have someone available, like almost like a 24-hour person in plan in place? And some people, they say to you, who's going to move in with you? I'd be worrying if I was down in Louisiana right now with a hurricane about to hit. Do you have electricity? Do you have them charged up? What's your plan if you can't get them charged? So you always have backup brains and backup batteries in the house, and somebody besides you knows how to do them as well, because if you have an event, you can't do it yourself. So how do they work? So you can see as this little picture on the right, there's two types. One that works intermittently and kind of makes the blood flow during systole and diastole. And the other one is continuous, where we want this continuous blood flow going through that circulatory system. So it's set at a speed. I wouldn't have a clue what flow speed is. I just know how they work. So as you can see, that intake cannula is located in that left ventricle. So the blood from the left ventricle, okay, is going to be sucked into the LVAD, or the left ventricular assist device. It's good oxygenated blood. And it then is going to go through an outflow cannula to the aorta so that we can get good continuous blood flow through that heart. Okay. Definitely going to be on anticoagulation because you have a foreign body in that left ventricle. But the complications, oh my goodness. Oops. Sorry about that. Sitting here and I bumped my mouse. Okay. There we go. So many complications. Infection is like number one because it's a daily dressing change. Thrombuses are huge. And again, they will be on anticoagulation. Another huge that I was really interested in reading about is how many people really get GI bleeding from these. And they don't really understand why, but the amount of cases of active GI bleeding is scary. And then these people are on anticoagulation. So it's kind of like a catch-22. Strokes are high. Because it's placed in the left ventricle, they can end up with right ventricular failure. Dysrhythmias can occur. So, but again, it's kind of a bridge. You're not looking good. And if I didn't say it, I want to say it again. The sad thing is when these go in, end of life issues are discussed because you're not going to keep this forever. And so when is it time to turn it off? Which is sad, but you have to be realistic about the LVADs. All right, so shock is really going to be covered more in 4, but we're going to talk about cardiogenic shock here because this is a great risk factor after an MI, but it's also a huge risk factor with the decompensated heart. So as we worry about who's at risk for cardiogenic shock, a lot of people, okay, structural problems, systolic dysfunction, diastolic, okay, both side heart failures. As you can see by that little middle one, again, that heart rate's going to be up so high trying to push blood around. Lack of oxygen in the brain is where that anxiety and delirium, high preloads, very high. Pulmonary congestion, obviously a decreased cardiac output because it's shock. So there's no blood going out. So then your body could go into shock, very dusky, narrowed pulse pressures. And this If you don't know what narrowed pulse pressures is, this is why trending is so important. We would look at patients to see if they have a widening pulse pressure or a narrowing pulse pressure. And people that are going into shock have what we call a narrow pulse pressure. So let's just say they've been running 120 over 80, 120 over 80. And as that pulse pressure narrows, you're going to start seeing like 90s over 60. So the diastolic number and the systolic number are becoming closer together. You are not perfusing well at that point. So again, with that low output, we get that activation of the renin-angiotensin system, but it won't work. So again, it just turns into this circulatory thing. So not good. Got to find out the cause, but it will kill these people. So let's take a look on this next slide a little bit more. So most common signs of cardiogenic shock is a low blood pressure. Your heart is not pumping, so you don't have a pressure, okay? Lack of O2 to the head, restlessness, dizzy, confused, probably nauseous. Extreme workload on the heart. Could be high, but it's going to get tired. It's going to get real weak. You're probably not palpating pedal pulses. Their radial pulses extremely thready. You stay at that apical pulse, feeling for a carotid, making sure that there's blood going up to that brain. Other signs, trying to breathe, okay? Severe shortness of breath. But again, engorged, bulging veins because that preload. It's because of preload. Cold and clammy. Could have loss of consciousness. Not urinating. Oh my God, now that you ask, I haven't urinated in days. So when people go into cardiogenic shock, we really do worry about the dysrhythmias. So we've got to treat them with the antidysrhythmics depending on what they need. Blood thinners. Again, if the atriums aren't emptying, we're worried about clots. So blood thinners, antiplatelet aggregates, anticoagulation, might even need a thrombolytic. Here's where we will start adding on things like vasopressors, trying to perfuse that kidney, inotropics, norepinephrine, dobutamine. We will talk about more of these drugs in shock. They will probably be on continuous renal dialysis just to maintain electrolyte balances in their fluids. They're going to be on a ventilator for respiratory support. We probably will have them on ECMO, which is extracorporeal membrane oxygenation. And this is actually where the blood circulates through a heart-lung machine to get oxygenated. Their heart isn't oxygenating the body, so we're going to do it for them. So again, pulls blood from the right side of the heart this time, where the LVAD pulled it from the left. We're going to pull it from the right, and we're going to oxygenate it, then turn it to the left side of the heart so it can perfuse the body. They might need what's called an intra-aortic balloon pump. This actually sits, we really don't use it as much as we used to because we do a lot more ECMOs, but it is temporary because what this does is actually placed in the aorta and it will pump and mimic diastole and systole to actually get the blood to move through the body. They might have percutaneous assist devices, ventricular assist, and I went through those. So in the LVAD, again, these are all temporary. So very scary, but at least in hypovolemic shock, I can give you some fluids. In cardiogenic shock, we have much more going on. So a little bit longer than normal videos, but we really covered a lot here. Thanks. Enjoy class.